It's my pleasure to call Dr. Panikar, sir. He's one of the very senior and very subtle speaker in Mumbai. So, sir is MD, DNB, FCPS, and FRCP from London, honorary consultant in Mumbai in many hospitals, and Department of Endocrinology and Diabetes, Metabolic Lilavati Hospital Attachment, ex-professor of medicine and KJ Sumaiya Medical College, Mumbai, ex-vice president for Research Society of India, and past chairman of RSSDI Maharashtra chapter, and past president of College of Physician and Surgeon of Mumbai, organizing chairman of RSSDI National Conference in Mumbai in November 2023. And there are a lot of publications, more than 20, and written chapters on textbooks and pioneering works in triple drugs therapy and low dose pioglitazone. I think many of us are the still found like to use pioglitazone. Sir is very much promoter of pioglitazone. And I'm a very avid follower of Panikar, sir, for pioglitazone. And to mention few more things, sir has got authored so many books and many guidelines also. So the floor is for the sir, and the topic is MSLD, a physician's approach to the management.
Thank you very much for a very kind and extensive. Can you hear me? Yeah. At the outset, I must congratulate Purvi, Manoj, and his entire team. The speed with which they have reorganized this conference. Full marks to them. I think they need an applause from all of you. In fact, Singh Saab and Sen Gupta, they have presented NFLD, and I think both of them, and I am also going to speak the same thing. So NFLD में ज़्यादा कुछ नहीं है. Just to understand the basics. Now, what should be the clinician's approach? Now, first is you have NAFLD. The name is being changed to MASLD. And why? Because what was NAFLD? Non-alcoholic fatty liver disease. Some people did not like the word alcoholic because ये बेवड़ा है, ये non-बेवड़ा है. So it's that way. So they decided, let's change that. Then they came fatty. अरे जाड़िया है, fatty. So that is where the change has come. Otherwise, there is nothing different. There is nothing different. Only that alcohol and fatty has been changed to metabolic. So renaming it to metabolic dysfunction associated with steatotic liver disease. And the reason is there were so many panelists, and I told you the reason already. And this renaming has been released in June 2023 and accepted and signed by all these gastro and liver associations. Now, basically, let us understand what is the definition. I will still continue with NAFLD because all of us like alcohol, all of us are fat, so there is no problem. Non-alcoholic fatty liver disease has been defined as accumulation of fat in the liver in the absence of recent or ongoing intake of significant amount of alcohol. I won't go into the details of this. And what is NASH? NASH is characterized by fat accumulation in the liver. That is steatosis. That leads to an inflammation and liver damage. That is what NASH is. Steatohepatitis. And this NASH, because of the inflammation, can progress to fibrosis, cirrhosis, and hepatocellular carcinoma. Simple. So fat accumulates, inflammation, fibrosis. NAFLD is a diagnosis of exclusion. So you remove alcoholic hepatitis, drug induced. You should be very careful. Tamoxifen is a drug used for CA breast, given over a long period of time and can give you a fatty liver. Amiodarone, which is used for cardiac arrhythmias, can give you a fatty liver. All the viral hepatitis, autoimmune hepatitis, can give you a fatty liver. Wilson's and hemochromatosis, though rare, I have seen very few cases of that, but it is there in the list. So it's a diagnosis of exclusion. And this is how it progresses from normal liver 5%, it goes to portal inflammation and then cirrhosis. But how does NAFLD really occur? We aren't exactly sure, but we have a decent idea. कि क्यों हो रहा है? It's a two-hit hypothesis for NAFLD. The first hit is that there is accumulation of triglyceride leading to steatosis caused by systemic insulin resistance. When there is insulin resistance, there is an increased mobilization of free fatty acids, which enters the liver, and that is where it gets deposited. The second hit was thought to be a consequence of long-term storage of these triglycerides in the liver, which leads to a hepatic oxidative stress. And in this paradigm, there is a perpetual chronic injury could be established, leading to eventual fibrosis, cirrhosis, and hepatocellular cancer. Now, subsequent studies have revealed that hyperinsulinemia, which is a reflection of insulin resistance, the first hit, does indeed precede the development of fatty liver in humans. So, in short, insulin resistance is the driving force for the development of fatty liver. The second hypothesis, multi-hit hypothesis, of course, looks at insulin resistance, metabolic syndrome, obesity, diabetes, hyperlipidemia. All of this which I just mentioned are part of insulin resistance. But you have altered gut bacteria, inflammatory cytokines, etc., which are add-on. Currently, this is the most accepted understanding for NAFLD. So this is how it happens. You have insulin resistance, metabolic syndrome, diabetes, obesity, which leads to NAFLD. And then you have that second hit, oxidative stress, inflammatory cytokines, gut dysbiosis, endotoxin, which lead to inflammation and further down. So NAFLD as a general rule seems to be that fatty liver is closely associated with insulin resistance. And there are very few exceptions to it. And those exceptions are hepatitis C, hepatitis B, and your familial heterogeneous hypobeta-lipoproteinemia. So basically you are looking at insulin resistance. Now everybody says NAFLD causes more cardiovascular problem, causes more stroke. Nonsense. It is insulin resistance which is causing more stroke, more cardiovascular problem, more atherogenesis, and NAFLD. It is not NAFLD causing that. So that is where we are. So the pathogenesis of non-alcoholic basic defect is the development of hepatic steatosis. And why does this happen? Because there is an imbalance between the import and export of fat from the liver. The free fatty acids, triglycerides get into the liver and it can't get out because they don't have much place to deposit that fat. So they get deposited in the liver. Insulin resistance with and without full-blown metabolic syndrome is a central mechanism of hepatic steatosis, which in turn develop in the setting of an inappropriate diet, sedentary lifestyle, obesity, advancing age, etc. So you have metabolic syndrome and NAFLD share very similar associations. What are they? They can have diabetes, they can have hypertriglyceridemia, they can have obesity, which is metabolic syndrome. Since metabolic syndrome risk factors so common in patients with NAFLD, there is evidence now to show that NAFLD may actually be a hepatic manifestation of metabolic syndrome. And what is metabolic syndrome? Again, insulin resistance driven. Everything boils down to insulin resistance. This was a paper we published way back in 2008 where we looked at the incidence of metabolic syndrome in type 2 diabetic patients, and it's almost 79% of type 2 diabetics have a metabolic syndrome. That means that is the incidence of insulin resistance in them. Today, NASH is becoming a leading indication for liver transplant in the United States and also in our country. Now, when you look at, this is from the ACE guidelines, which was published in Endocrine Practice in May 2022. I won't go into these details, but look at it. Patients with type 2 diabetes, the last paragraph, have extremely high risk of NAFLD, and up to 90% have non-alcoholic fatty liver disease, type 2 diabetic, 90%. And about 37% have NASH. And 20% of the patients with type 2 diabetes have significant fibrosis. This is from the ACE guidelines, May 2022. And basically what these guidelines were trying to show is raising the awareness that NAFLD is very common. See, every type 2 diabetic that you see has a fatty liver till proved otherwise. It's not the other way around that you have to look for it. You have to assume that they have a fatty liver till proved otherwise. Let us look at the Indian scenario. We are going to talk about Indians here. We are the thin, fat Indian. You look at this, Yutsky and Professor Yagnik, both have the same BMI, 22.3. But look at the body fat. Yutsky has 9.1% and Yagnik has 21% for the same BMI. So we are thin, fat Indians. And data from India support the higher prevalence of IR in patients with AFLD. These are some studies which have shown higher insulin resistance and higher hepatic triglyceride in Indians in comparison to other races. Peterson and all have shown that hepatic triglyceride content and plasma interleukin in different ethnic groups, and he showed that they are highest in Indians compared to any other ethnic population. So what am I trying to tell you? That we are basically an insulin resistant population. And that is why we have an early onset of type 2 diabetes, we have early onset of atherosclerosis and coronary artery disease, and we have worse coronary artery disease. And that is the main reason, because we are an insulin resistant nation, ethnically. Peterson also looked at various risk factors, and he found that in spite of having a lower BMI, Asian Indians had the highest levels of fasting serum insulin and insulin resistance in comparison to other Eastern Asian, Caucasian, blacks and Hispanics. So we are insulin resistant. Now, the Indian scene. Important to note that Indians have excess body fat, as seen by the thin fat Indian, abdominal obesity. Even I have it. I can show it to you if you want. I had kept this generally to show you all only. Diabetes is quite common, hypertriglyceridemia and insulin resistance. And these are highly prevalent in the urban Asian Indians. And this is what is important in the pathophysiology of NAFLD. So it's reasonable to presume that NAFLD would also have a very high prevalence in Indians here. If insulin resistance is the driving force, you have an ethnic community which is predominantly insulin resistant, they are going to have fatty liver. So we need to be looking at that. This was a study which we did last year for exactly 2 months in my clinic, only in my morning session of my clinic, where we did a fibroscan for every patient who came, every diabetic patient who came. And in those 2 months, in my morning session, 1,521 diabetic patients were screened. And what did we find? Out of that, 75% had significant fatty liver. 27.88% had fibrosis. We have repeated this same study just 2 months back, and again for 2 months, where we have done 3,000 patients scanning. And we have got data now of this first last year's group and this group who have been treated, and we see a good improvement. And there we have been using a lot of pioglitazone and saroglitazone, your lipaglyn. Good results we have been seeing. That data is being analyzed, and maybe sometime next time I might give you that data too. So recent updates in management of NAFLD, lifestyle modification, diet control, weight reduction is the first thing. Anything that will cause weight reduction is going to reduce insulin resistance. So if you give a GLP-1, you give a SGLT2, you diet and exercise, you have a weight reduction, your insulin resistance come down, will have a beneficial effect. You should treat the comorbid conditions of the obesity, that is your type 2 diabetic, hypertension, dyslipidemia, treat it as you are going to treat. And you have pharmacotherapy and bariatric surgery. Now here, I'll just skip because of lack of time. Weight reduction can significantly improve. If you have a look at the bottom, 3% weight reduction, steatosis improves. 5% ballooning improves. 7% NASH improves. And more than 10% even fibrosis regression. But what is the sustenance of this? Very poor. Less than 10% of the people will sustain that weight loss. That is where the crux of the matter is. If you look at all the randomized controlled trials reporting improvement in NASH, look at it. First, resolution of NASH. What is the drug? Pioglitazone, 45 and 30 milligram is the best which is seen there. Liraglutide does show a good improvement. You look at NAFLD, again pioglitazone. Steatosis, pioglitazone. Lobular inflammation, pioglitazone. Fibrosis, pioglitazone. Ballooning, pioglitazone. What does it tell you? That you treat insulin resistance. So, key ACE guidelines again of May 2022 was consider medications management using pioglitazone or a GLP-1 analog for those with NASH and type 2 diabetes. Consider weight management medication like semaglutide, liraglutide for BMI about 27 in the presence of NASH. Consider bariatric surgery for individuals with BMI over 35 and NAFLD. Screen children for adolescents for type 2 diabetes. This is again the ACE guidelines which says that you give pioglitazone and GLP-1, high strength of evidence, grade A. Clinicians must consider treating diabetes with pioglitazone and GLP-1, and to offer benefits, you can add a SGLT2. GLP-1, pioglitazone and SGLT2. If you have the fibrosis risk stratification at any level of fibrosis risk stratification, again the same formula works, but if you see SGLT2 is added everywhere to pio and GLP-1. What does the ADA of 2023 says? Use pioglitazone or GLP-1 analog, and that is grade A evidence. Mind you, till now no FDA has recommended any drug for fatty liver. But this is the ADA guideline. We have seen the ACE guideline. But now we have a drug which has been approved by our Indian drug controller, Zydus saroglitazar for non-cirrhotic, non-alcoholic steatohepatitis. And the approval was based on the results of evidence 1, 2 and 4 studies. And I'll just show you some of them. But what is saroglitazar? It is a dual PPAR agonist, both alpha and gamma. Basically, the gamma is just like pioglitazone. It reduces insulin resistance. The alpha works on reducing the triglyceride. And that is the mechanism with which this drug works. And in my practice, I use a lot of pioglitazone. But of late, I have been using a lot of saroglitazar also in those patients where I cannot give a pioglitazone, and with good results. And the numbers are huge. I think some data will come very soon. So if you look at it, it improves insulin sensitivity, which is comparable to pioglitazone. You have evidence on, efficacy is NAFLD. This is study done from USA. I think this idhar ka part is not coming. I don't know why. Steato means the SGOTPT, the first one, 43%. Reduction in transaminases, reduction in fat liver content, and so on. It does work. So recent guidelines have come, but are they already outdated? To my mind, yes. 2023 and 2022 guidelines. They say bariatric surgery, GLP-1, PPAR gamma, SGLT2 and saroglitazar. But now we have newer molecules. We have a tirzepatide, which is a dual PPAR gamma, dual GIP and GLP-1 agonist. You have a 20% weight loss in them. Fantastic. Which will clear the liver absolutely. And you look at this, recent guidelines, the ACE guidelines came in May 2022, which said, but on May 13, that was 1st May 13, US FDA approves tirzepatide, dual GIP-1 GLP analog. It is very good for type 2 diabetes, for NAFLD, reduces SURPASS trial showed effect on type 2 diabetes, SURMOUNT trial shows effect on weight reduction, CVD benefit is shown, fatty liver effect is shown. So this is where we are. And now we have a new molecule, a triple agonist, Retatrutide. That hits a new high in weight loss. This is a GLP-1, GIP, and a glucagon agonist. So 3 in one injection. And what it shows at 24 weeks with an 8 milligram dose, retatrutide produced complete resolution of excess fat in about 80% of the people. Complete resolution. Fat nikal gaya. Where are we? This is the future. And when you look at the same study where they looked at 48 weeks, this was 24 weeks, 90% of the people had fat gayab. That is where. So when you add a glucagon activity, one of the 3 agonist action in this retatrutide, liver fat clearance goes up tremendously. So this is the future. But today what do we have? We only have a pioglitazone and a saroglitazone. GLP-1, yes. But what percentage of your patients can afford the GLP-1? Hardly. It costs $10,000 a month. How many can afford that? So that is where we are. So Indians have the highest prevalence of insulin resistance, no doubt about that. Diabetes and cardiovascular disease start much earlier in Indians as compared to other ethnic groups. Insulin resistance plays a pivotal role in the development of NAFLD or MSAFLD, whichever you want to call it, CVD and stroke. Treating insulin resistance aggressively as early as possible is the surest evidence-based approach to minimize the deadly effect of looming epidemic. That means use pioglitazone from day one. If you treat insulin resistance, you will prevent your patient from getting fatty liver, and you will treat his fatty liver if he already has one. It is anti-atherogenic, it will protect his heart, it will protect his brain, it will not give him stroke, and the patient will be happy. This is a sound. We are going to have the RSSDI in November 16, 17, 18, 19 at the Geo Center. And the last RSSDI in Mumbai was held in 2011 at the Renaissance, where again I was the organizing chairman. And it is 12 years now since the last. And a Kumbh Mela is held once in 12 years. So now we come to the Kumbh Mela of diabetes. Thank you.